Hello everyone, welcome to HIM 225. This lecture is covering Chapter 15 in your textbook. And Chapter 15 actually includes 3 chapters from ICD-10. Chapter 6, which is diseases of the nervous system. Chapter 7, which is eye and adnexa. And Chapter 8 is ear and mastoid process. So if we go in and we look at Chapter 6, we can see that we do have some excludes notes 2 at the beginning of this chapter. And of course we know that excludes note 2 means that these are things that we may need to code in addition to the codes from Chapter 6. And you'll see things here which absolutely make sense. Complications of pregnancy, injuries, neoplasms, signs and symptoms. Then we have our section list, and I'm not going to read those to you, but you need to take time to review those. And of course, as always, I encourage you to look at the acronyms and abbreviations that are at the beginning of this chapter. Look at the glossary terms that are at the end of the chapter, and then review the chapter review exercises that are part of your homework. You do not have a workbook assignment for Chapter 15. Now, if we look at Chapter 7, we can see that these are diseases of the eye and adnexa. And there is a note here that tells us to use an external cause code following the code for the eye condition if applicable. And typically that means that there was some type of injury or assault to that eye and adnexa area. That's commonly people have issues with their eyes related to shrapnel or a foreign body or something like that. Now, of course, as a reminder, we have the external cause tab here. So if we're looking for external cause codes, we're going to be clicking on this particular tab. And as we look at the section list, we can see it's not extensive, and it is specific to the anatomy of the eye typically. Okay, and then if we look at Chapter 8, diseases of the ear and the mastoid process, again, we have that note about external cause. Sometimes there are foreign bodies that get into the ear, and you would want to code that. I don't know if you guys ever watch YouTube videos. Maybe you've seen Dr. Pimple Popper. Maybe you've seen the physician from Great Britain who is their equivalent of Dr. Pimple Popper. There are also some from Asia that have videos out there. Interesting to me are the videos of the providers that are doing extractions of foreign bodies in the ear. Unbelievable what some people get in their ear. Wax, they'll do wax removals. And now you can even buy these little tiny flashlights that you can put into someone's ear and visualize it all the way to the eardrum. I was showing that to a friend of mine, and they said, oh man, I need that for my dog, so I can see in my dog's ear and see when they're all gunked up. So I just thought that was interesting. I love to watch those things. I think they're amazing. And then you can see our section list here for the ear and mastoid processes is quite a bit smaller and less complicated. Often these are types of diagnoses that you see treated in the outpatient setting and procedures performed on an outpatient basis as well. Now, we're going to go over the guidelines that are in your textbook. And I also want to encourage you, as you're reading the chapter, you need to take time to look in all the chapters, not just this one, in all the chapters. You need, towards the very end of the chapter, you will find the Z codes that are typically related to this particular chapter in ICD-10. If you look in your textbook on pages 354 and 355, you will see all of them, many of the Z codes that would be relevant. So you'll see that there are encounter codes here for examinations and evaluations related to the eyes and the ears. And then the other thing I want to make sure that you take a look at are the procedures that are related to this section. So on page 356, you can see the different procedures that are typically related to this particular chapter. And I encourage you to try and code some of these. Go into the procedure tab and put in some of these codes, look around at them, be familiar with them. So now let's go back to page 333 in your textbook, and the first thing that we're going to talk about is dominant, non-dominant side. And this is particularly relevant for patients who have had some type of neurological event that has affected one side of their body. And of course, the perfect example of this is a patient who's had a stroke. And patients have a dominant or a non-dominant side, or they may be ambidextrous. And I'm not sure, neurologists may be very good now about documenting which side the patient is dominant on, whether they're right-handed or left-handed. Nursing does a patient assessment, and they ask the patients, are you right-handed or left-handed? So you can always look in that nursing assessment to find that documentation if the physician doesn't provide the documentation. And of course, the right hand is considered to be dominant. The left hand is considered to, well, let me take that back. If a person is right-handed, then their right side is their dominant side, and their left side is their non-dominant side. But if they are left-handed, the left side is their dominant side, and the right side is their non-dominant side. And the coding guidelines tell us that if a patient is ambidextrous, it doesn't matter which side is affected, you code it to the dominant side because they're ambidextrous. Now, what the guideline also tells us is that if there is no documentation about which side is dominant for the patient, basically you assume that the right side is. And if the right side's affected, you code it as dominant. If the left side's affected, you code it as non-dominant. So if they're right-handed and it affects the right side, dominant. If they're left-handed and it affects the left side, dominant. Then the other side is considered non-dominant, and if you don't know, you assume they're right-handed. Now let's look at category G89. Category G89 is the category for pain. And you can see that it says pain not elsewhere classified. And we have a number of notes here to look at related to pain. You can see that we do have an instructional note here. We talked about this with chapter 14. Code also related psychological factors associated with pain, and it gives you the code right there, F45.42. So that's a great reminder that if there's a psychological component, you do need to add that code, and it's not 45.41. This category excludes generalized pain. That's a sign and symptom code, R52. It excludes pain disorders that are exclusively psychological. We know that that code's F45.41. We talked about that in chapter 14. And then just the code for pain not otherwise specified is R52. There aren't too many times when you would use just a generalized pain code or a pain NOS. And of course, we know from having worked in the sign and symptom chapter, we don't code pain that is expected. It's expected when a patient has surgery that there will be post-op pain. Well, unless the pain is more than is expected, it's not coded. Even they, of course, will treat patients for expected pain. So you have to be careful when you're coding that pain. You see that we have an excludes note 2 here, so these are codes that can be assigned in conjunction with the pain, because this pain code can give more information about the type of pain that the patient has. You can specifically assign a code for either acute pain or chronic pain, and those pain due to trauma, post-thoracotomy, post-procedural pain, neoplasm-related pain. And I want to mention that with chronic pain syndrome, that is a specific condition, and you don't assign a code for chronic pain syndrome unless it's specifically documented. You don't ever assume that a patient has chronic pain syndrome unless the physician tells you they have chronic pain syndrome. So as we look at this first guideline on the bottom of 333, basically it tells us if the pain's not specified as acute or chronic, if it's not specifically one of the categories, acute, chronic, post-thoracotomy, post-procedural, or neoplasm-related, you do not assign a code from category G89. So the documentation has to be specific to the codes that are in this category. A code from G89 should not be assigned if the definitive diagnosis is known, unless the reason for the encounter is pain control or management and not management of the underlying condition. So there are times when patients who have cancer, who have malignant neoplasms, are specifically admitted for pain control. And in that instance, pain can be listed as the principal diagnosis code. And you may recall that when we covered Chapter 11, we had a guideline, Admission Encounter for Pain Control Management. It's actually on page 221 in your book. And it says that we apply, basically it tells us to go look at the guidelines for pain control and management. So in this guideline, basically, it tells us that if that admission is for control of pain, we apply that as the principal diagnosis code. It also tells us if the admission or encounter is aimed at treating an underlying condition, such as a spinal fusion or a kyphoplasty, a code for the underlying condition, it could be a vertebral fracture or it could be spinal stenosis, that should be assigned as the principal diagnosis code, and there is no code from G89 that would be assigned in those instances, because they're bringing the patient in with a specific condition, they're treating that specific condition, and they are not treating the pain. And of course, this could be when a patient comes in to have a neurotransmitter placed so that they can help control the pain. Having a procedure done that will treat the condition that's causing the pain, such as a spinal fusion or kyphoplasty, vertebroplasty. So in those instances, we don't assign a code from G89. Now, I want to go back to the example on page 333, the first one, the patient admitted to the hospital for treatment of a CVA. Patient has hemiparesis of the right side. And I want to show you, I'm going to, that CVA, that is a cerebrovascular accident. So I'm going to go to accident, and I can see cerebrovascular. I63.9. Let me click on that code and verify it in the tabular. And that says cerebral infarction unspecified, stroke and OS. And we really don't have any other information about this cerebral infarction to be able to assign a more specific code. If I go to the beginning of this category and look, which I should always do, there is an includes note here. There's a use an additional code, which doesn't apply to us. And then an includes and an excludes note, which also do not apply to us. So that I63.9 code is about as specific as we can get. That used to be the code we used all the time, but now with technology, CT scans, MRIs, it's much easier to get much more specificity and assign more specific codes. Now, we have to assign the hemiparesis for this patient. And so for hemiparesis, it says C, hemiplegia. So I'm going to go to hemiplegia, and I see hemiplegia following cerebral infarction. Here I have stroke and OS. We're going to choose that code. You'll see that stroke and cerebral infarction are the same code, I69.35, and there's a dash after that. So I'm going to come over here, and this is sequela of cerebrovascular disease. And if I go down and look through this category, I can see that I haven't excluded. Let me go to the beginning of this. And this tells us that this code is to be used to indicate these are the cause of a sequela. Sequela is a late effect. And then we have an excludes note 1, which are the personal history codes. I'm going to go back to 3.5. Now, I want you to notice that this category, I69.35, is hemiplegia and hemiparesis following a cerebral infarction. And as we look at the codes, we can see that this was the right side. It doesn't tell us whether this was dominant or non-dominant, so we're going to assume dominant. And this code, I69.351, hemiplegia and hemiparesis following a cerebral infarction affecting the right dominant side. So this is a code that tells us that this patient had actually had a cerebrovascular event with a late effect, a sequela of the hemiplegia. When you look at your textbook, this is not the code that your textbook uses. It gives you the code for the nonspecific CVA, and then it gives you the code G81.91. And if we were coding a chart, we would very clearly understand whether or not the hemiparesis was present on admission or if it was considered to be a result of the CVA. This patient may have actually had a CVA previously, and it was the sequela of a previous CVA. So if we just look at this code for hemiplegia, G81.91, if we go to G81.9, this is hemiplegia unspecified. 91 is specific to affecting the right dominant side. And remember, the guidelines tell us if it's not documented that we use right dominant. And so that's what we're doing here. So then the appropriate way to code this particular example, if I were coding it and I just looked at this, I would think this patient had come in with a CVA and now has a sequela of the CVA, which is the hemiparesis. And I wouldn't code it the way the book has it. When I look at it, I'm thinking, well, they coded it that way because they're not implying that the hemiparesis was a result of a CVA. So I'm going to go to the sequela codes and also look at this. So if I go to sequela and then stroke and then look at hemiplegia, it sends me to the I69.35 category, which is where we went to start with. And then I would choose 1 for the right dominant side. So There are two possibilities for this question. The patient comes in for a CVA, and they also have hemiparesis, which is not documented as being a late effect or a result of that CVA, or the patient's coming in with a CVA and they have hemiparesis because of the CVA. Either way, it's two codes, I63.9 and G81.91, or I69.351, depending on the documentation. So I want you to read that, and if you don't understand that, let me know. But it's very important to understand that typically when you see this documentation, you think that the hemiparesis is because of the CVA, but if it's not linked, if it's not documented that way in the chart, if it's not clear, then you may need to query the physician. For this lecture, I want you to go to exercise 15.2 on page 349, and you're going to be answering question number 9. And for this question, there is just one code. You're just going to be coding the fact that the patient has the right-sided hemiplegia, which is the late effect of a stroke. You're not actually going to be coding the stroke, so just one code for that late effect. That will conclude this first lecture for Chapter 15.